with the next topic.
Yes, sir. Good evening, sir.
Hmm.
My question is, a 28-year-old female posted for oocyte retrieval developed severe bronchospasm, facial edema, hypotension after induction with thiopental and succinyl choline. How to manage? My diagnosis anaphylactic shock in non-operating room anesthesia procedure. My concern is Nora and patient in lithotomy position, sir. Definition: anaphylaxis is defined as a severe, potentially life-threatening systemic hypersensitivity reaction. Pathophysiology: hypersensitivity is a type 1 hypersensitivity reaction. It can be immunological, IgE mediated, and non-immunological, non-IgE mediated, or idiopathic. Immunological of anaphylaxis is due to cross-linking of IgE antibody. It can lead to degranulation of the mast cells and basophils. This degranulation release of mediators like histamine, prostaglandins, proteoglycans, and cytokines. Repeated exposure to an allergen, activation of T helper 2 cells, and sensitization of these cells. This sensitization initially does not cause any clinical manifestations. Non-immunological anaphylaxis, it is non-IgE mediated, does not involve immunoglobulins, and due to direct effect on the mast cells, like any drugs, cold, and exercise. Common trigger agents are in 60 to 70% under anesthesia. It's due to non-depolarizing muscle relaxant. Neuromuscular agents like vecuronium, atracurium, saxacurium, pancurium, rocuronium, and vivacurium. Antibiotics, penicillin group of drugs, thiopentone, there is 1 per 14,000 patient reported. Latex allergy and plasma expanders like dextrans and colloids. Clinical features. Common feature is cardiovascular. Cardiovascular is hypotension, tachycardia, and cardiovascular collapse. Any arrhythmias. ECG changes from ischemic changes to cardiac arrest. Respiratory system, edema of the tongue, airway, and glottis. It may cause stridor and airway obstruction. GIT, abdominal pain, diarrhea, and vomiting. Hematological manifestations, if any, leads to coagulopathy. Cutaneous symptoms, flushing of the skin, erythema, and urticaria. Diagnosis: anaphylaxis is a clinical diagnosis. Anaphylaxis should be suspected if there is unexplained hypotension, refractory to vasopressors, or unexplained difficulty in ventilation and bronchospasm. The grading, Ring Mesmer grading scale is used to assess the grading of anaphylaxis from grade 1, generalized mucocutaneous symptoms, grade 2, mild organ manifestations, grade 3, multiple organ manifestation, grade 4 is cardiopulmonary arrest. Differential diagnosis: depth of anesthesia. If it is too deep, it can lead to hypotension, and if it is light, it can lead to bronchospasm. If any inhaled foreign body, acute asthma, vagal syncope, or any hypovolemic shock or septic shock. Management: immediate management, stop injection or infusion in process, call help, inform surgeon, and switch to 100% of the oxygen. Drug of choice is adrenaline. IM 0.5 to 1 ml of 1 in 1000 dilution. Titrate to response. If milder reaction, give ephedrine. IM dose, if patient is adults, dose is 500 mics. Patient children less than 6 years, 150 mics. 6 to 12 years, 300 mics, and more than 12 years, 500 mics. Intravenous, adults 50 mics, and children is 1 mics per kg. IV should be given very cautiously by anesthesiologist or intensivist. Start rapid intravascular volume expansion, 20 ml per kg, Ringer lactate solution, or normal saline or plasma light. Elevate the legs, it can improve the venous return. External cyst compression if cardiac arrest. So subsequent management: antihistamines like chlorpheniramine 10 to 20 mg slow IV injection, and steroids, hydrocortisone 200 mg IV slow injection. If persistent bronchospasm, salbutamol can be given via nebulized breathing circuit or meter dose inhaler, or IV infusion 3 to 20 mg per minute. Aminophylline loading dose 5 mg per kg IV, and infusion is 0.5 mg per kg hour. Check ABG after 20 minutes of resuscitation. If any severe acidosis, can consider soda bicarbonate 0.5 to 1 millimole per kg. infusion for persistent cardiovascular instability, like adrenaline infusion and noradrenaline infusion, and vasopressin also may effective. And simultaneously, how to check clotting screen. Consider any coagulopathy. Post-crisis management, ICU admission if a patient is airway, breathing, and circulation should be adequately checked. Investigations like ABG, renal function test, LFT, to check hypoperfusion of the organs, plasma total tryptase level, and any allergic testing, skin prick test, and the fluoroaminoassay. Prevention, thorough medical history of a patient obtained from any undergoing anesthesia. There must be careful for any predisposing factors or any positive history of reaction during anesthesia or any previous contrast allergy, and any family history of atopy should be elicited, sir, before giving anesthesia. That is.
What is the importance of measuring the tryptase level?
Confirms the diagnosis of.
When should it be done? When does it increase and how long will it remain elevated?
It should be taken within 6 hours of anaphylaxis.
So that is also an important thing to prove that it is anaphylaxis if there is a litigation. Okay? When you say the patient developed all the clinical features of angioneuritic edema, bronchospasm, hypotension, and supposing it ends in a mortality, unless you have the tryptase value being measured and documented, this will maybe contested in the court of law. Okay, so you have to, for the sake of medical legal aspect also, tryptase estimation is very, very important. Okay? And you mentioned only about the non-depolarizing muscle relaxant. Does dexamethasone have the ability to produce?
Yes, sir. I informed, sir. Dexamethasone.
Here, which one you think is the culprit, thiopentone or dexamethasone?
Dexamethasone, sir.
Mostly it is dexamethasone. Very rarely thiopentone also can produce. Okay, any drug is capable of producing this sort of anaphylaxis, and that is what we have to mention about that. And the main drug is epinephrine. That should be highlighted. Okay, not ephedrine, but epinephrine is the drug of choice for immediate treatment of anaphylaxis. That is what the examiners expect from you. So just see, we have the So this is a 28-year-old female coming for oocyte retrieval. So they have used thio and scoline for this. So anaphylaxis is defined as a severe, potentially life-threatening systemic hypersensitivity reaction. And out of this, culprit can be either thio or Axa. The pathophysiology of anaphylaxis is caused by immunological mechanism or non-immunological mechanisms or idiopathic. So it can be anything. So in this case, what do you think it is? Immunological or non-immunological?
Non-immunological.
Non-immunological. And IG mediated always requires a sensitization phase, that it should be first exposed to the particular antigen so that the reaction occurs. And exposure to the allergen activates the T helper cells and the production of IgA antibodies. and the Ig binds to the FEC receptors on the mast cells and basophils, causing sensitization of these cells. So the initial sensitization has no clinical manifestation in the immunologically mediated anaphylaxis. And when there is a re-exposure to the allergen, the receptor bound to Ig aggravates and stimulates the sensitized mast cells and the basophils to degranulate, and they release the mediators like histamine, prostaglandin, proteoglycans, cytokines, etc., which all lead to the clinical manifestation of anaphylaxis. Whereas in the non-Ig mediated anaphylaxis, the hypersensitivity reaction is stimulation through Ig and immune complex complement mediated pathway. And this non-immunological mechanism of anaphylaxis does not involve immunoglobulins and due to direct stimulation of mast cells by the causative agent. And these are the stages. So there are two stages in the immunoglobulin mediated anaphylaxis. One is the sensitization phase, the second is the re-exposure phase. So their mast cells and basophils are in a sensitive state, and again when the re-exposure occurs, the whole thing gets released and the clinical picture appears. And the risk factors for triggers are the atopy, drug and food allergy, systemic mastocytosis, and other clinical presentation. Common perioperative triggers are neuromuscular blocking drugs, antibiotics, and latex. These are the common things which are less commonly chlorhexidine, even the cleaning agent that we use, the colloids or blue dyes, and heparin, protamine, and oxytocin. These are also drugs which are notorious for producing anaphylaxis other than the anesthetic agents. And neuromuscular blocking agents, prochronium and suxamethonium. And how do you diagnose anaphylaxis? The clinical diagnosis. Mostly laboratory tests are not useful in diagnosing anaphylaxis at the time of presentation, but they take time to process and are prone to false negatives and positives. So patients may present with acute onset of generalized mucocutaneous signs, respiratory compromise, and cardiovascular instability. So these are the three important presentations: mucocutaneous signs, bronchospasm in the respiratory tract, and cardiovascular instability in the form of hypotension. And these signs may present in isolation or in combination. So if it happens as a mucocutaneous signs of edema of the eyelids and lips and rashes, that is a very minor grade of anaphylaxis. On the contrary, if it is associated with bronchospasm, it is a moderate degree of anaphylaxis. And if it is associated with sudden acute hypotension, it is a very severe degree. So diagnosis anaphylaxis can be difficult because the signs may also arise from other anesthetic and surgical causes in the perioperative setting. So it should be suspected when there is an unexplained hypotension which is refractory to vasopressors, and unexplained difficulty in ventilation, and bronchospasm which is not getting easily relieved. Now grading is done by this ring Messmer grading, where it is a simple mucocutaneous signs like erythema, urticaria, or angioedema, or it can be multi-organ manifestations, mucocutaneous signs, bronchospasm, hypotension, severe life-threatening multi-organ manifestations like arrhythmia, cardiovascular collapse, bronchospasm, and cardiopulmonary arrest suddenly occurring immediately as soon as the drug has been given, which is considered as grade 4. Now, what is the immediate management? Stop the suspected trigger, secure the airway, give high flow oxygen, administer adrenaline in titrated doses with close hemodynamic monitoring. So, this is the major treatment, and the dose of epinephrine for grade 1 to 2, that is simple erythema, urticaria, angioedema, or bronchospasm, hypertension, Adult dose, it is 5 to 20 micrograms IV. Okay, and children 1 to 5 micrograms. Whereas grade 3, there it is a life-threatening arrhythmia and other things are present. 100 to 200 micrograms IV for adult and 5 to 10 mics IV for child. And grade 4 can straight away push 1 milligram IV or 0.01 milligram per kg IV. And if intravenous access is not available, then only you go for intramuscular, where you can give a maximum of half a cc or 500 microgram. And children less than 12 years, you give 300. Less than 6 years, you give 150 micrograms. And post-crisis management can give steroids and antihistamines after the initial resuscitation. Steroids, dexamethasone 0.1 to 0.4 or hydrocortisone 2 to 4 milligram act by inhibiting the transcriptional pro-inflammatory proteins and may be effective in biphasic reactions. And oral antihistamines may be effective in grade 1 anaphylactic reaction, that is angioneuritic edema and urticaria. And combination of H1 and H2 receptor antagonists like diphenhydramine and ranitidine may be more effective than the diphenhydramine alone, that is Benadryl. And intravenous antihistamines, they have a risk of causing hypotension if given rapidly and the tissue injury if extravasation occurs. And when intraoperative anaphylaxis occurs, it's prudent to conclude the surgery as soon as possible. So tell the surgeon it has happened and better not to proceed if you are not started. And how long these patients need observation and why? Postoperative intensive care admission should be organized for monitoring this patient's condition can be prolonged up to 32 hours and it has a biphasic reaction occurs. That initially, what is this basis of biphasic reaction? Several hypotheses of biphasic reaction have been propagated. One is inadequate treatment in the initial resuscitation, release of late phase mediators from immune cells, delayed absorption of antigen from the gastrointestinal tract to the systemic circulation, the activation of secondary mediator pathways. So how does tryptase help in anaphylaxis? What is the pattern of its release and what is the normal value? Plasma tryptase levels may help to support the diagnosis. Normal value is 1 to 15 nanograms per ml. And tryptase level peaks within 15 to 120 minutes, that is in 2 hours of the onset of anaphylaxis, and start declining slowly back to baseline levels by 24 hours. So you must take a sample if you are diagnosing anaphylaxis within 2 hours of the occurrence of the anaphylaxis, so that you have a maximum level of tryptase that is present in the blood. The normal value is only 1 to 15 nanograms. It will raise several fold, like your cardiac enzymes raising in myocardial ischemia. This will also increase several fold, which will be the method to prove that it is an anaphylaxis. Okay. So that is the thing that we have to remember.